Yeah? Let's go to the cancer.
We can just take the questions in the end, I think.
Okay, good. In cancer, the cancer itself doesn't do that much to sexuality. It's a traumatic experience. It can be a blow to identity and sometimes to the relationship. But the damage in cancer is far more than 95% is by our treatments. And we have to realize that's different from many of the chronic diseases. That's the strategies would damage so much, both to the function, the relationship, and the identity. The desire, sexual desire, is influenced very much by castration. And of course, we do a lot of castration in patients with cancer. We don't call it castration, but if you remove the ovaries already sometimes in a normal hysterectomy, but in ovarian cancer, in bladder cancer, in endometrium cancer, in cervix cancer, mostly we remove also the ovaries. That means castration. That means you lose 50% of your testosterone supply. If you add, after that, the chemotherapy, then you get really into problems. Because, later on, first the hormonal therapy. In some of the patients, we give hormonal therapy, especially in the prostate cancer patients. If the cancer is inside the prostate, you can treat it locally. If it's outside, you have to treat it generally. And that we do it by taking away the fuel for the cancer cells, and in prostate cancer, they can grow better by testosterone. So we remove the testosterone, but then he has no testosterone for desire, for assertiveness, for getting horny, even for falling in love. It's all disappearing. And he's tired also. So that is a side effect of the hormonal therapy, and that can be very heavy. Then the next is the chemotherapy and the radiotherapy. Especially if you have radiotherapy for all the body, like we do in leukemia, then you do total body irradiation, and then you give stem cell transplantation afterwards. Then you damage also, especially the testes, the ovaries, and the adrenal glands, and they function much less afterward. So if you have ovarian cancer, you remove the ovaries, you give chemotherapy, and afterwards your testosterone level is very much down. And I saw in Rotterdam, I had quite a big group of patients with ovarian cancer, and many of them, they were complaining of no desire, no sensation in the genitals. They said, it's just like dead flesh down there. They couldn't get an orgasm. They lost their power in their job or in the relationship, and sometimes in the normal, the small fights between partners, they lose, and that can be very damaging to a person if he or she is no more the one she was in interrelationships. You get it also a lot in blood and lymph cancer, where you give this total body irradiation or chemotherapy, and you get it also in breast cancer. In breast cancer, it's very complex. On the one hand, we interfere with hormones. On the other hand, you should like to give them back hormones, but the hormones you give them, they have an influence in the vagina with the tamoxifen, which is sometimes positive, sometimes negative, and people are very, very, very scared to add a little bit hormone for sex. Now you get into a very complex situation, especially in breast cancer, but also in some other cancers, that those patients who really are greedy to have good sex, that many doctors say, no hormones, no hormones. On the other side, you have patients who say, I don't want any hormone because I want to live as long as possible. I want to see my granddaughter get her final examination. I want to have the 50th anniversary of my wedding. So no any hormones. And it's not up to us to decide, it's up to the patient to decide. And that is what up till now, usually we have not learned how to deal with this and to have this discussion and to allow the patient to be so full of sexuality that she or he needs additional hormones, even if that gives some more percentage of cancer risk. It's up to them, it's not up to us. It's like we are not allowed to forbid them to smoke, even if we know that they have more risk for lung cancer. This is Sigrid. She was 32 years. She got leukemia, she got total body irradiation, stem cell transplantation, and most probable she's now completely cured. And she comes through the GP to the sexologist. She has no more sexual desire, and she's very tired, and she has also amenorrhea because the ovaries don't function well. Now, one of the important reasons, and that you see quite frequently in some chronic diseases, but especially in young people with cancer, is the infertility. They can't get children, and if you can't get children, it's a blow to your female or male identity, and that's a good reason to have low desire. But with this story, these are three things who all three could be as well a result of low androgen, low testosterone. And then it can be useful to test the testosterone in such a person and to supply testosterone. Now, testing it in a woman, it's difficult because most laboratories don't do that. So you have to make a connection to mostly to the gynecological endocrinology, and then they know how to test it. But in fact, you can do it regularly on the clinical picture. If the patient of course, if a patient never was very much into sex, and then she has cancer, and then after that I have no desire, and now I have the possibility to talk about it, that's different. But if you've got a patient who says, I was very much into sex, I loved masturbation, I loved to grab my husband, and it's completely gone, and even with a strong vibrator, I get maybe that little orgasm instead of what I had in the past. That is a very clear sign of a very low testosterone. It's a clinical sign. I didn't need, after 10 patients, I knew very clearly I didn't need to test in the lab. If she has such a story, it's testosterone for sure. And then you can replace that. Here you see what it does in a graph. Now, in the excitement phase, I said already it's more important for the male identity because it can be easily solved in the woman. This is influenced by the interventions in the pelvic area, by surgery and radiotherapy. Colorectal cancer, we know the deeper you go into the pelvis, the more risk that you damage the nerves for the erection. And of course also the nerves for the lubrication, but that's less important as a real problem for the women. Now, if you relate them high in the colon, they have about 40% damage, low in the rectum, it's 86%. So no more erection. Now, again here, this 86%, for some men, okay, that's bad luck. For other men, it's very important that they have no more erection. That's, for instance, you see that much more important in the gay community. Gay people get cancer as well. Nature is not discriminating. They do it to everybody. And especially the gay people, when they get cancer, they get more problems because the gay men, they need the sexual performance more within their way of living. Now, in prostate cancer, of course. In prostate cancer, when you operate, usually you cut the nerves. Now, we can treat prostate cancer, local prostate cancer, we can treat it in 3 different ways. If you do a complete dissection of the nerves, if you don't do nerve sparing, which still is done by some doctors, then if it's completely cut, you have no more erection and you won't get an erection back after some time. If you do radiotherapy, in the beginning it will be okay, but it will get worse and worse and worse after 1.5 to 2.5 years. It goes down. It's like a Chernobyl effect. It takes long before the damage is real there. If you do the proper nerve sparing, you still pull on the nerves and you have the catheterization in the neighborhood, so the nerves are damaged in a way but not cut completely. And they regenerate, but it takes 1.5 to 2.5 years. Now, in the meantime, you have to take care that the corpus cavernosum is regularly functioning. And in the corpus cavernosum, you need oxygen. That is what we do every night. As soon as we fall asleep, after 1.5 hours, we get our REM sleep. And then during the REM sleep, you get erection. And the women get, during the REM sleep, they get lubrication. And then it falls back. Now, if you have got this nerve damage, it doesn't happen. Now we have to do that artificially. And that is what we call now the, you see it's endothelial damage and cavernosal damage because you get a lot of fibrosis. What we do now is penile rehabilitation, either by low dose of the PDE5 inhibitors, for instance 5 milligram tadalafil, or by intracavernous injections, giving several times a week, giving an injection inside the corpus cavernosum, or by vacuum therapy, and even you can try to do it by vibrator and a lot of striptease and touching the penis. You can get as well a lot of rehabilitation and take care that there is sufficient oxygenation, and after 1.5, 2 years, then it will return as good as possible. Now about orgasm. Surgical damage again to the nerves. You find that most clearly in the young man with the testis cancer, where they remove the glands on the side of the aorta. Then you regularly get the retrograde ejaculation, that the urine goes into the bladder instead of to outside. Oh, sorry, the semen. And of course, here you get a lot of problems with the SSRIs from the antidepressants who act especially on orgasm.